Pusat Jantung Nasional Harapan Kita, kebanggaan Indonesia, denyut masa depan kesehatan bangsa, wujudkan Indonesia bahagia, profesional inovatif mendunia, humanis harmonis terpercaya, pengampu rujukan seluruh Nusantara, hidup berkualitas untuk Indonesia. Rumah sakit jantung dan pembuluh darah, harapan kita, mengemban amanah cita mulia, jayalah selalu selamanya. Harapan kita, harapan bangsa, harapan sehat para cendekia. Harapan kita, harapan semua, harapan untuk Indonesia. Pusat Jantung Nasional Harapan Kita, kebanggaan Indonesia, denyut masa depan kesehatan bangsa, wujudkan Indonesia bahagia, profesional inovatif mendunia, humanis harmonis terpercaya, pengampu rujukan seluruh Nusantara, hidup berkualitas untuk Indonesia. Rumah sakit jantung dan pembuluh darah, harapan kita, mengemban amanah cita mulia, jayalah selalu selamanya. Harapan kita, harapan bangsa, harapan sehat para cendekia. Harapan kita, harapan semua, harapan untuk Indonesia. Pusat Jantung Nasional Harapan Kita, kebanggaan Indonesia, denyut masa depan kesehatan bangsa, wujudkan Indonesia bahagia, profesional inovatif mendunia, humanis harmonis terpercaya, pengampu rujukan seluruh Nusantara, hidup berkualitas untuk Indonesia. Rumah sakit jantung dan pembuluh darah, harapan kita, mengemban amanah cita mulia, jayalah selalu selamanya. Harapan kita, harapan bangsa, harapan sehat para cendekia. Harapan kita, harapan semua, harapan untuk Indonesia. Pusat Jantung Nasional Harapan Kita, kebanggaan Indonesia, denyut masa depan kesehatan bangsa, wujudkan Indonesia bahagia, profesional inovatif mendunia,
bisa dengar ya Bu Jessica, Dr. Dicky, Fakhri, Dr. Dicky Hanafy.
Ya, selamat pagi Prita.
Selamat pagi Dok. Dr. Duddy mungkin bisa diaktifkan videonya. Oh.
Good morning, everybody.
Morning, Dick.
Good morning, Dr. Ron Binsu, Dr. Dicky Fakhri.
Yeah,
Good morning, Dick. Good morning, Prof.
Yeah. Good morning.讯号好像没有那么好。
Professor Rombin, I've read in CNN there were no new cases of COVID in Taiwan. Is that true?
Yeah, yeah. In Taiwan, the COVID-19 the local case is almost zero. So
wow,
we don't have to wear the mask during the daily activity. Yeah,
oh,
but however, for the
amazing.
medical personnel, we still use the mask.
Oh, yes, but that is amazing if you almost no local kids anymore. That's
yeah,
great.
that's all the effort from our people and also our government. How about the situation in Indonesia?
It's
So
still bad. It's still
It's
bad,
bad.
actually.
But everything will be gone.
Yeah. Well, hopefully it will be soon better when we start with the vaccine, but still there still needs some time to deliver it.
Yeah.
Yes. So in case you're wondering, there's Dr. Dicky Fakhri over there, and my name is Dicky Hanafy. So Dicky is a common first name in Indonesia, but we are not related. But my relation is actually to the other speaker, Dr. Duddy Hanafy, who is my twin. So I'm a cardiologist. I'm a cardiologist, and Dr. Dicky Fakhri, who is the Director of Medical Service in Harapan kita, he's a surgeon, cardiothoracic surgeon. Yeah, cardiothoracic surgeon. My twin brother, Dr. Duddy, who is the other speaker here later, he's also a cardiothoracic surgeon like yourself.
Yeah, great to see you.
Great to see you too.
Shall we start with Prita?
gentlemen, welcome to the collaboration webinar between National Cardiovascular Center Harapan Kita Indonesia and National Taiwan University Hospital Taiwan on the theme of PAM CABG experience. My name is Nofrita. It's a wonderful chance for me to be your master of ceremony and such an honor for our National Cardiovascular Center Harapan Kita, having National Taiwan University Hospital and all medical experts gathered here. Before we proceed the program today, we would like to express our sincere gratitude to Dr. Dicky Fakhri, PhD, Director of Medical Services, Nursing and Supporting NCVC Harapan Kita Hospital, and Dr. Yinsar Cheng, Director of Cardiovascular Center, Department of Surgery, Division of Cardiovascular Surgery, National Taiwan University Hospital, Honorable Distinguished Speaker, respected delegates, distinguished medical professional, and everyone here. The first agenda is opening remarks from Director of Medical Services, Nursing and Supporting National Cardiovascular Center Harapan Kita Hospital, Dr. Dicky Fakhri, PhD. Without further ado, please welcome Dr. Dicky Fakhri to deliver opening remarks. The time is yours.
Thank you very much, Dr. Prita. Good morning, everybody. Hope you are doing well. We met again on another webinar collaboration between National Taiwan University Hospital and National Cardiovascular Center Harapan Kita Hospital. Today's topic, we are going to talk about OPAM CABG. I think it is very challenging topic for today because as we know, there are some advantage if we do the operation with OPAM CABG. As we know, the technique already has been used since 30 years with many discussion or debating about the disadvantage and disadvantage. Today we are grateful to have Professor Ron Bin-Shu from National Taiwan University Hospital and Dr. Hanafy from National Cardiovascular Center Hospital to share their experience in performing OPAM coronary artery bypass graft procedure. As we know, Dr. Duddy is a senior cardiac surgeon in our hospital. He do a lot of case OPAM CABG in our hospital, and also I'm sure Professor Robinsu do a lot case with the CABG without using heart-lung machine. Once again, on behalf of National Cardiovascular Center Harapan Kita and on behalf of President Director Harapan Kita Hospital, we do welcome you all. Thank you for all participants and speakers. Let's enjoy the webinar. Thank you very much. Back to you, Dr. Prita.
Thank you very much, Dr. Dicky Fakhri, for the opening speech. And today we have a moderator for the scientific session is Dr. Dicky Armen Hanafy. Dr. Dicky Hanafy is a senior consultant of cardiology, division of arrhythmia, National Cardiovascular Center Harapan Kita. Please welcome Dr. Dicky Hanafy. The time is yours.
Thank you, Dr. Prita. Hello and good morning to everybody. So I'm honored to moderating the session, and we have two distinguished speakers here, Dr. Duddy Hanafy and Professor Ron Bin-Shu. We will start the session with Dr. Duddy Hanafy as the first speaker. Introduction was already been given by Dr. Dicky Fakhri. If you're wondering why our last names are the same, well, we are brothers, we are twin brothers, but okay. He's the cardiothoracic surgeon and I am the cardiologist. Okay, Dr. Duddy Hanafy, are you ready to give your talk?
you, Dr. Dicky Fakhri, for organizing this webinar and the panelists and the organizing committee for this webinar. It's a great opportunity to be here. Today I will present, maybe we can share the slides, the off-pump experience in the National Cardiac and Vascular Center here in this hospital, Harapan kita. Can you see my slides?
Not yet.
No, not yet. Yes, we can see it now.
Yes. Clear now.
Okay, yes. Next slide. I have no conflict of interest related to this presentation. Okay. Recently performing myocardial revascularization, we showed the aid of coronary for this heart-lung machine, or called also off-pump coronary artery bypass or OPCAP, has become a promising alternative. We can see here that the using of CVV, cardioplegic, cardiac arrest, or aortic cannulation, aortic cross clamp can lead to, if we don't use it, less inflammatory response, less oxidative stress, less myocardial reperfusion injury, less activation of complement cascade. That's why avoiding the CPB, the periprocedural mortality and complication could be reduced. Next slide. According to ESC or AX guideline, OPCAP should be considered in the subgroup of high-risk patients by experience of pump patients, or of pump teams, I mean. Hello? Yes. This is from the ISMIC study, showed that it is reasonable to perform OPCAP to reduce risk of stroke, renal dysfunction due to renal replacement therapy, blood transfusion, respiratory failure, and reducing risk of wound inspection. The consensus also stated here that OPCAP significantly reduced ventilation as you can see here, that OPCAP showed may be associated with higher graft occlusion at short-term 30 days and long-term 1 year, and also increased coronary reintervention in 1 year. How about OPCAP experience in the National Cardiovascular Center Harapan kita? In our hospital, OPCAP is considered as an alternative, especially in high-risk patients. Until now, we continue to improve our skills and experience in OPCAP. There are more than 100 OPCAP per year in this hospital, with a proportion about 24% OPCAP and 76% CABG. Here's the data of off-pump and on-pump CABG in Harapan kita from 2018 and this September 2020. There were around 1,800 patients underwent isolated CABG. That's our 400 off-pump and 1,400 on-pump procedures. From the characteristic, we see there's no significant difference. There were also no significant difference in the pump function and total graft between the two groups. But you can see here, the pump function in the off-pump group is lower than the on-pump group, but it's not significant different. Next slide. From the perioperative variables, we can see about blood transfusion is that off-pump needs less blood transfusion. Next slide. Here we can see duration of ventilation, the ICU and hospital length of stay is also significant better in the off-pump group. Next slide. How about the post-operative complication? We can see stroke, atrial fibrillation, renal failure, and sepsis are not significant, but perioperative myocardial infarction is significant. Next slide. MACE is not significant, but the mortality rate is significant, 2.7% to 5%. Next slide. How about the cost? We also do a cost analysis, and we can see the total cost of off-pump is in Indonesian rupiah 79 million, and the on-pump is 89 million. That's a different about 10 million Indonesian rupiah. It's about $800 US. Next slide. This is a study conducted by Forozania, found that the mean cost was mortality, perioperative low cardiac output syndrome, and reoperation. This leads to the conclusion that OPCAP is the preferable technique when dealing with patients with low ejection fraction and low ischemic burden. Okay, for summary, as there are multiple evidence of low mortality rate and fewer incidents of MACE linked to off-pump CABG, but we should always keep in mind to fit the procedure to the patient, not the patient to the procedure, because both off-pump and on-pump have strengths and weakness. In high-risk patients, OPCAP has been established as a safe and effective alternative procedure. We can see also that OPCAP recommended to reduce need of transfusion, duration of ventilation, post-operative complication, mortality, and cost. However, the consideration to perform OPCAP surgery depends on the experience and comfort level of the surgeon. Thank you very much. I appreciate the opportunity to share my thought.
Thank you, Dr. Duddy. Hanafy, excellent presentation, clear and concise. Now we move on to Professor Ron Bin Su. We have the honor to have Dr. Ron Bin Su from the National Taiwan University Hospital here to speak about his experience in off-pump CABG. Professor Ron Bin Su, good morning. The time and it's yours.
Yeah, thank you. Can we see the screen?
Duddy, you have to unshare your slides so Professor Ron Bin Su can share his slides. Okay.
Good. Yeah, it's my great honor and a privilege to be here to share our experience of OPCAP in our hospital. I'm Professor Rongbin Su. Currently, I'm the Chief of Cardiovascular Surgery. As we know, the CABG can be performed in 3 ways. The first, the conventional one, is on pump with cardiac pressure arrest. The second was OPCAP without the support of cardiac pulmonary bypass and without the cardiac pressure arrest. And the third in between, the on pump and the beating heart, it means that the use of the bypass but no cardiac pressure arrest. This kind of technique, the OPCAP, not a new thing. It has been used by the Russian surgeon Korisov in 1967. However, that technique was difficult then, so it was abandoned because of difficult technique. However, in recent 20 years, there were several assist devices to facilitate the performance of OPCAP, including the mechanical stabilizer, intracoronary shunt, and the several assist procedures. However, overall, the OPCAP technique was still technique demanding, and it was beneficial only in high-risk patients. The assist device include the left side is the mechanical stabilizer. You can stabilize the target vessel and reduce the relative motion of the target vessel. The second was intracoronary shunt to reduce the bleeding when you are performing the arteriotomy. As we know, there are several advantages of OPCAP. The first was no cardiac pulmonary bypass. They will decrease the transfusion requirement, decrease the instant of stroke, and also several post-operative complications. The second was no LT cross-clamping. It means that there is no myocardial injury during the procedure, so it will decrease the myocardial injury, also improve the perioperative outcome. However, there are several disadvantages of OPCAP, including the incomplete myocardial revascularization, especially for the young surgeon, and also the early anastomosis dysfunction. Therefore, it is very important to have experienced surgeon to perform the OPCAP procedure. And the general consensus was that comparing the outcome of OPCAP and the outcome CABG, there was lower mortality or complication rate only in high-risk patients, and there was no significant difference in median or risk patient. There are several studies supporting the OPCAP, including the single surgeon study, the single institutional study, also the registry study. However, in randomized control trial, the result didn't support the OPCAP. Why? Because there are several limitations of the OPCAP study. The first was the patient selection. As we know, for a single surgeon study, single institutional study, the registry study, the procedure was always performed in selected patients and also experienced surgeon. However, the randomized control trial, the patient was highly selected and performed in some inexperienced surgeon or unexperienced center. For example, the first randomized study was reported in the year 2009 in New England Journal of Medicine. It compared almost 1,000 cases between the OPCAP and on-pump CABG. They exclude 99% high-risk patients in this study. However, as we know, the high-risk study was especially beneficial in OPCAP. And also the surgeon experience, it seems like to be unexperienced because the average bypass vessel for coronary artery is less than 3 per patient. And there was also very high conversion rate, over 10%. Therefore, in our hospital, we start to do the OPCAP in the year 2000. We correct our first 1,000 case experienced in the year 2012. This is the unselected and the consequent patient cohort. We try to find the surgical proficiency and some quality indicator for the OPCAP. Our OPCAP team includes the surgeon, me, and several surgical residents and the major 2 anesthesiology and several scrub nurses, and also we set up a protocol of care in ICU and the general ward. Our purpose of this study is to find the single surgeon experience in unselected patient cohort. We want to know the real surgical outcome and try to find the quality indicator for OPCAP, and also try to find the required case number of surgical maturation. We divide our patient in 11 periods by every 100 cases. We defined some indicator. The first was the revascularization index. It was the number of distal anastomosis divided by the number of diseased vessels. Our transfusion policy is a liberal transfusion strategy to keep the hemoglobin over 10. And for the elective cases, we will discontinue antiplatelet 3 to 5 days before the operation. We don't use the cell saver or any antifibrinolytic agent in our study. In the OPCAP procedure, we usually use the scalonized internal mammography and the open method for the second event harvest. This is the assist device we use. We use this kind of mechanical stabilizer and the intracoronary shunt, and also the blower. We don't use the apical positional, nor any pericardial stitch for traction. Sometimes for diffuse coronary disease, we have to perform coronary endarterectomy. It takes about 3% in our cases. The coronary endarterectomy can be long segment or limited segment. These are our results. Our patient, the median age was 65, and the 3-vessel disease more than 80%, and lemon disease about 1/3. And the patient was presented with shock in 6% and emerging cases in almost 10%. Our mortality, the hospital mortality was dependent on the operating status. For elective cases, the hospital mortality is about 0.4%. And for urgent cases, about 8%. For emergent cases, about 32%. Even in the patient with age over 80, for elective cases, the operating mortality is about 2%. The major stroke occurs in less than 1%, and the sternal wound infection about 2%, and the reoperation for bleeding about 1.4%. And the number of anastomosis per patient was 3.4 per patient. Was 3.4, and the revascularization index is 1.2, and the conversion rate for non-emergent cases is about 6%. When we divide the patient by 100 cases per year per patient, we find for the first period, the first 100 cases, the number of distal anastomosis is about 2.5. With surgical maturation, the number of distal anastomosis will increase from 2.5 to 4 per patient. For revascularization, revascularization index, you can find that the revascularization also increased from 1.0 to 1.4. For the conversion rate in non-emerging cases, it will decrease from 23% to less than 5%. And also the transfusion rate for all cases, it will decrease to less than 30%. When you compare the maturation period, you can find the transition for the number of distal anastomosis, the transition long occurs between the 600 to 700 cases. Also, the revascularization index. For the conversion rate, the transition long is about 200 cases. Therefore, our conclusion that we defined the three major quality indicators for the OPCAP. The first was the number of distal anastomosis should be more than 4 per patient. And the conversion rate for the non-emergent case should be less than 5. And the rate of blood transfusion should be less than 30%. And we estimate the required level of surgical maturation. For conversion rate, it takes about 200 to 300 cases. For complete revascularization and also the blood transfusion, it takes about 600 to 700 cases. And the current status, we have more than 1,500 cases. And the conversion rate currently is less than 3% in non-emergent cases. There was almost no blood transfusion in non-anemic patients. And also, we try to go down the length of sternum wood to less than 15 centimeters. So that's the we definition for a qualified OPCAP. The complete revascular rate. The number of distal anastomosis should be more than 4, and conversion rate should be less than 5% in non-emergent case, and the no blood transfusion if the patient was not anemic before operation. So our message was that, okay, still the technique demanding. You have a very good patient selection and very good surgeon experience. In my belief that the OPCAP is good, it's more cost effective, especially in developing countries, because there was no cardiopulmonary bypass, less blood transfusion, less post-operative outcome. There will be short ICU stay and a hospital stay. Thank you.
Thank you, Professor Ron-Bin-Su. Excellent presentation and very good data about your experience in your personal experience in NTUH. So we move on to the discussion. For all attendees here, please type your questions in the question box if you have any questions, and I will try to forward your questions to the presenters. And well, I see here there are no questions yet. So I would like to ask Dr. Duddy Hanafy, is there any difference in your procedure of OPCAP with the one that Professor Ron-Bin-Su is doing in NTUH? And if yes, what are the differences?
Yes, we use apex suckers. Professor Ron don't use it, and we also don't. The same is also we don't use pericardial stitch, but we use apex sucker. The rest is, I think, is almost the same. And about the graphs, we have a mean graph of 2.8, and Professor Ron has right now is around 4 anastomosis per OPCAP.
Okay. So I saw in your presentation, Professor Ron-Bin-Su, that you have a difference between urgent and emergency operation. With the emergency is quite high mortality of 32%. What is the difference between emergency and urgent? Why is the mortality that high in emergency operation?
Yeah, for emergency case, the patient always were presented in shock status. Always required some kind of mechanical support, including the intra-aortic balloon pumping, even the ECMO support for this kind of patient. Yeah, so that's why the operating mortality for the emergency case is more than 30%.
Yes, of course, if this is so these are patients with circulatory support, I guess. Yeah, then that's in overall already a high risk patients. But urgent, what is your criteria for urgent?
Yeah, the definition of the urgent operation is the same as we use internationally. If the patient was admitted by some disease, not by the surgery itself. For example, the patient has acute coronary syndrome, unstable angina, and he required urgent operation for revascularization. We define these kind of patients as urgent cases.
Okay, so the problem is in a patient with acute coronary syndrome. Do you have a lot of patients with acute coronary syndrome, or wouldn't that need better? I mean, if they have a acute infarction, wouldn't it better just to wait the infarction or do the PCI first, or do you have a lot of patients where you directly go for coronary artery bypass in these kind of patients?
Yeah, especially for patients with significant limb disease and also the triple vessel disease. And the data shown that for this kind of patient, the outcome of CABG was much better than the PCI alone.
Okay, you would not do bridging first PCI for the most critical lesions, and then maybe wait 4 weeks until the patient recovers. Then do the CABG.
So if the patient need the surgery, you can perform the surgery.
Okay.
At the right now.
I don't see any questions yet. Maybe Dr. Duddy or Dr. Dicky Fakhri have any questions, or Dr. Ron Bin Su, maybe to each other.
May I ask Professor Ron?
Yeah.
Yes, please.
Yes. You say that you don't need any blood transfusion with if the patient is not anemic. Do you use kind of cell saver intraoperatively?
Yeah, you know the cost of a cell saver is high. But we try to lower down the cost of the operation. So personally, for my team, I don't use the cell saver for blood correction. Yeah, especially when patient the hemoglobin is more than 12 before the operation. Yeah, you don't have to worry about the blood transfusion issue.
My next question is, do you use a CO2 blower for the anastomosis? Like when I was in Japan, they don't use it.
Yeah, I don't use the CO2. Yeah, I also don't use the CO2. I try to keep the technique as simple as possible.
Okay. If you can see here on the monitor, there is a question for Professor Ron Bin Su. Why complete revascularization can't be accomplished by OPCAP procedure? Is that true? You cannot do complete revascularization? What do you think, Professor Ron Bin Su?
I think the major problem for the OPCAP, especially for the young surgeon, is try to expose the the lateral side, the lateral circumflex artery. Yeah, you have to rotate the heart to the right lateral position in very extreme position. So you will compromise the hemodynamic during the exposure. We use the several kind of assistant, including the table rotation, and try to use some drop to maintain the blood pressure. So it will give me a good chance to do the complete revascularization. When your surgical technique was mature, gradually, you can do more anastomosis for every patient.
Okay. Thank you, Professor Ranbin Su. Any comments, maybe Dr. Dicky, Fakhri?
As we know, the surgeon experience very, very important for the OPCAP. When you reach the required case number for maturation, you can do complete revascularization.
So you have fellows in your center.
Yeah.
How long do they train under your supervision until they can do proficient OPCAP procedure?
Yeah, I think my presentation is my personal experience. I do the OPCAP in a hospital from the beginning. So I think the learning curve can be shortened by the training by a experienced surgeon. So personally, for training for a young surgeon, I always stand behind the young surgeon to facilitate the exposure and also osmosis for the coronary artery.
Okay, there's another question here coming in. Why don't you use the apex sucker, Professor Ron?
Yeah, I think there are two major reasons. The first is the cost of the apical suction. The second is I'm afraid of the potential injury of the heart by the apical suction. And I find that by using my technique, I can expose the circumflex artery or even the RCA easily. You know, I have a standard procedure for the exposure. You know, I always make a video for the resident to find the best way to expose the difficult coronary artery target. So
if we want to learn your technique, Professor Ranbin Su, about this, if we send a surgeon to you in your center, would you be able to show us maybe what do you think? How many procedures did he need to see to maybe him himself can do this procedure?
I think it's very quite easy. You know, I have been in Vietnam and also in the Mongolia to show my technique for the OPCAP. Yeah, when they find when they see my procedure, they always say that I know how to expose the heart during the circumflex and the RCA exposure. You know, it's very easy. It's very easy, but you have to see. Yeah.
Okay.
Yeah. And then my colleague said that we always welcome you to come to our hospital for learning. Yeah.
Oh, that's great. Thank you very much. Another question is coming in here. What is the criteria for conversion to on-pump CABG? And is there any tips for young surgeons that want to do OPCAP? The question is directed to Professor Ranbin Su again.
Yeah, that's a very, very good question. Yeah. When we see the literature, you find that the urgent conversion is very dangerous for the patient. but the elective conversion is not. So it is very important to find the optimal timing for conversion to avoid the urgent conversion. What is the criteria for conversion to unpumped CABG? When you expose the blood pressure cannot maintain by the usual technique, you have to consider the conversion, not put the patient in dangerous situation to convert to the unpumped. So the first thing is that to do the OCAP is that you have to try to expose the heart, including the RCA or the circumference artery, and then ask the anesthesiology to do some procedure for that. If the blood pressure and the heart rate, especially arrhythmia, is stable, you can perform the OCAP easily. But if you cannot put the patient in very good blood pressure and even some arrhythmia, especially for the ventricular tachycardia occurring during the exposure, you have to consider elective conversion, not emergency conversion.
Okay. Thank you for your tips and tricks. And now maybe Dr. Duddy has any other comments or questions? No. Or maybe Professor Ron, any comments or questions about the experience in Harapan kita?
Yeah, my comment was that I'm the first surgeon to do the OPCAP in a hospital. I try to keep every patient in OPCAP. When you put every patient in OPCAP, you will learn a lot of things from that. When you do every procedure in OPCAP, you can shorten the learning curve for that. So, for me, it's almost 95 or even 100% of OPCAP in my personal CABG patient.
But you still do other operations like valve replacement and everything else?
Yeah, of course. Personally, my favorite was heart transplantation.
Okay.
I'm a transplant surgeon.
So are there any other questions? Dr. Frita, maybe, do you see any other questions? I don't see any other questions here. Yes, Dr. Duddy? Duddy Hanafy.
No, I don't have any other question.
Okay. If there are no other comments, maybe Dr. Dicky Fakhri may have any comments. If not, then I would close this session. Okay. I cannot hear you, Dr. Dicky. Dicky Fakhri. No, I cannot hear you. You're still mute. Hello. Dr. Dicky Fakhri.
Dicky is saying something. 其实我学这个单单就这个技术，那1个月就够了。
Dr. Frita, kok nggak ada suara ya, Dr. Dicky Fakhri?
当然，如果他同时要学其他技术，就可能要更长。他transfer他就要更久。因为我们1年大概20几个，所以要有 case 他才学得到。对，可能要办。单单学 OCAP 其实1个月看一看就够了。
但我觉得他们应该要想发展。
transfer 要看你有 case 才有办法。没有 case 你来没有。
比较长一点时间。
对。
我还记得尼玛第一次看到就去取经。
Hello.
Yes,
Can
yes,
you
we
hear
can
me now?
hear you now.
Yeah, I was mute by organizing committee. I can do it from here.
Oh, really? Okay.
Yeah,
Sorry
yes.
about that.
It was a nice presentation, Professor and Dr. Duddy. We learned much from you because in our hospital, maybe Dr. Duddy is one of our senior cardiac surgeon, do a lot of the op-pump CABG. According from your speech, that maybe in the next year, Dr. Duddy has another junior can send to your center to learn how like a tip and trick, for op-pump CABG. I think it's very nice presentation today. Thank you, Dicky.
Yeah, thank you, Dr. Dicky Fakhri. A bit, or maybe Professor Ron Bin-Su can come to our center when the COVID situation has improved to show his techniques to our surgeons here, maybe next year or something. That Professor Ron Bin-Su can come here and show his techniques.
Yes, I think it is a good idea, Dr. Dicky. I think it's a good idea. If the pandemic situation getting better in the next year, we will invite you to show your tip and trick.
That would be great. Okay, if there's no further questions or comments, I would like to summarize this session that OpCamp surgery has a lower risk compared to on-pump CABG procedure, especially in those in high-risk groups. There's a significant difference in mortality and morbidity. It is safer, it is more cost-effective, and there are several techniques there are several technique differences in both centers that makes this also a unique way of operation. Of course, emergency procedures are always connected with high mortality in any kind of surgery, also in off-camp or even on-camp surgery. And we see here that the conversion rate in both centers are quite low. So experience is the key in this kind of off-camp operation. I thank you, Dr. Duddy Hanafy, Professor Ron Bin-Su, and Dr. Dicky Fakhri for your time here and for your presentation. I would like to close this session and wish you all a very nice weekend. Thank you all.
Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you very much.